Hi ma'am, sometimes we see that patients have a thin endometrium. What is this, how does it happen, and how can it cause infertility?
The inner lining of the uterus is called endometrium. It's a very dynamic tissue. It can be divided into two parts, the basal endometrium and the functional endometrium. The basal is the one which is stuck to the muscles of the uterus, and the functional is the one which grows and sheds in every menstrual cycle. Normally after menses, the basal endometrium starts growing in response to the sex hormone estrogen, and it grows to, in the first 14 days up to a size between 9 to 12 millimeter. The basal endometrium divides into three types of cells: the vascular endothelial cells, the glandular epithelial cells, and the stromal cells. And all these three type of cells play a very vital role in embryo implantation. And normally, when the endometrium is between 9 to 12 it is best for implantation. Anything less than 6 millimeters, usually these patients do not show embryo implantation and they fail even in IVF.
Okay ma'am, what kind of procedures can we do to improve this thin endometrium? Intrauterine PRP is one of them, but what are other ways in which we can do this?
Before we go to the treatment aspect, let us understand that why this endometrium becomes thin. One, this endometrium is completely dependent on estrogen for its growth and differentiation. So if enough estrogen is not received by this endometrium, then probably it remains thin. And this can happen because production of estrogen is less, or because the supply of estrogen to the basal endometrium is less, because the vessels have undergone fibrosis, which happens in tuberculosis. The second is, apart from estrogen, it is the amount of basal endometrial cells, if they are damaged or if they are removed or aspirated during a DNC. Usually we have a history in these patients that a missed abortion was there and a curettage was done, and then after that they started getting scanty menses. So it is a destruction of basal endometrium itself, either by tuberculosis or by a surgical procedure, that the endometrium continues to remain thin. So the treatment would be according to the cause. If estrogen is less, we can increase the estrogen by correcting the cause of low estrogen. Then if the vascular flow to the basal endometrium is less, we can increase the vascular flow to the basal endometrium with certain medicines like sildenafil and L-arginine. And if the number of basal cells are less, then they need to be treated either with stem cells. So bone marrow derived CD134 stem cells are put through the femoral vein or the femoral artery into the spiral arteries by the fluoroscopic procedure, like you do the angiographies and all. It can be put in the basal endometrium, the stem cells, or we can do a hysteroscopy and transfer PRP, platelet-rich plasma. We know that the blood has got white blood cells, red blood cells, and platelets. And platelets have lot of growth factors. At any site of injury, it is the platelet which brings about healing and growth of fresh tissue. So injecting platelets in all the walls of the uterus with the hysteroscopy with the help of a needle helps in a great way to rejuvenate a thin endometrium, followed by giving doses of estrogen to these patients.
What kind of results have you seen in your experience, ma'am, with such treatments to treat thin endometrium?
Well, if it is only because of low estrogen, it's a wonderful result. If it is because of low blood flow to the uterus, we can still have good hope. If it is because of damage to the basal endometrium, depending upon the amount of damage is the success. If the damage is minimum, usually the women will have menses. Although scanty, they will have menses, and having menses is a big hope to rejuvenate the endometrium. But those who are absolutely without any menses, which means that they lack the basal endometrium completely, these are the most difficult cases and they may need a surrogacy. The ones with thinner endometrium, of course, still have to have a lot of patience, because repeated hysteroscopies may be required. Maybe 1 or 2 times PRP may be required. It may take 6 to 8 months, but still keeping patience does help in treating patients of thin endometrium.
Thank you, ma'am.